Compartment pressure, increase osteofacial compartment pressure that stops the capillary that exceeds the capillary pressure. Osteocompartment pressure raises, decrease perfusion, irreversible muscle and nerve damage. Symptoms: number 1, pain; number 2, pain at passive stretch; number 3, paresthesias; number 4, pulselessness; number 5, paralysis. There is tense swelling, high clinical suspicion. Sensations goes before paralysis because fibers carry sensations more sensitive to increased pressures. So sensation is more responsive to pressure. Clinical delta P is important. McQueen PJ 1996 study difference between the measuring intracompartmental pressure and diastolic pressure if less than 30 mmHg is diagnosis if taken prior to GA. If the patient is anesthetized, then the diastolic blood pressure, which was before GA, should be tested. More reliable than absolute pressure of more than 330 millimeter Hg that was by Mubarak et al. High CK can diagnose muscle necrosis. When prospective study by McQueen, differential pressure of 30 mmHg as a threshold for fasciotomy led to no missed compartment syndromes. Indication: number 1, patient is not alert, unreliable; number 2, inconclusive physical examination; number 3, unequivocal clinical findings should prompt emergent operative treatment without need for compartment measurement. Technique: within the measurement should be done within 5 centimeters of fracture site, needle perpendicular to the skin. Bose guidelines for compartment syndrome: number 1, assess after all major injuries, prolonged surgery, clear documentation. Number 2, pain on passive movement is a key. Number 3, neurovascular assessment should be documented, but it's not a diagnostic tool. Number 4, patients at risk should have an hourly compartment nursing observation. Number 5, avoid regional anesthesia in high-risk patient. That will mask up the compartment syndrome. Number 6, if suspicious, release dressing of the skin to skin level, maintain BP, keep limp at the level of the heart, and reassess in 30 minutes. Number 6, consider compartment pressure optional, but all units should have access to compartment pressure monitoring equipment. Number 7, surgery within 1 hour once decision is made. Absolute pressure more than 40 mmHg or delta P less than 30 mmHg, convincing clinical sign. Document compartment pressure, depression, debridement, uh, decompressed, document compartments decompressed, debride muscle second look within 48 hours, and early plastic surgery involvement. Late presentation, more than 12 hours as high risk of complication rates. 2, consultant to decide operate and non-operative management. 2, consultant decision to operate and non-operative management is an option. 2, incision fasciotomy technique, cuff. Anterolateral incision. Anterolateral incision 2 centimeter anterior to the fibular shaft. Find and protect superficial peroneal nerve. Find anterior intramuscular septum. Release anterior intramuscular compartment longitudinally halfway between the intramuscular septum and the tibia. Release lateral compartment in line with the fibula. Danger of superficial peroneal nerve is there. Posterior medial incision 2 centimeter posterior to posterior medial edge of the tibia. Incise posterior superficial compartment. Release superficial posterior deep compartment. Can not be done without proper elevation of soleus muscle. Examine epimysium and incise when tight. Prevent retraction of skin edges with tension vessel loops weaved through staples or shoelace technique. Postoperative delay, postoperative delayed primary closure or wet dressing or skin graft 3 to 7 days. Neglected compartment syndrome, observe and do denulisis later on. Decompression can kill patient by rhabdomyolysis.